So after the recording, I'll start with this session is brought to you by CareEpilepsy Ethiopia, a dedicated non-governmental organization working to improve the quality of life for people with epilepsy. And since its inception, CareEpilepsy has played a critical role in raising awareness, training healthcare providers, offering patient support, and advocating for better access to epilepsy services. I'm Dr. Salim, a clinical care and training lead at CareEpilepsy Ethiopia, and I'm honored to be hosting this event. So for those of you who joined later, let me introduce you with the title again. So today's title is Epilepsy and Anti-seizure Medications, Advances in Research, Diagnosis, and Treatment. We are excited to have you with us today. So we'll cover about central role of anti-seizure medications in epilepsy management, available medications in Ethiopia with their mechanism of action, ongoing challenge of side effects and drug resistance. We encourage all participants to stay actively engaged throughout the session. Please note that certificates of participation will be provided to those who attend the full session. So I think we can go on and introduce our speakers for today. Sorry, let me let in more people. Okay, so we are honored to welcome two distinguished speakers for today's webinar, both of whom bring a wealth of expertise to improving epilepsy care. Dr. Etsegenet Tizazu, a neurologist and epileptologist trained at University of Pennsylvania. She currently serves as a board member of CareEpilepsy Ethiopia. Driven by a personal mission to fight the stigma surrounding epilepsy, Dr. Tizazu has been instrumental in advancing epilepsy care in Ethiopia. Her work includes forming the country's first functional international Bureau of Epilepsy, leading initiatives to expand access to anti-seizure medications. Thank you, Doctor, for your inspiring leadership and dedication. Our next speaker, Dr. Yeshewaneh Beyene, Doctor of Pharmacy, is a clinical pharmacist and senior medical science liaison with extensive experience in both hospital and pharmaceutical industry settings. A graduate of Texas Southern University, Dr. Beyene has worked for over 20 years in pharmaceutical research, with a particular focus on epilepsy medications. He brings a valuable insight into the clinical and research aspect of anti-seizure drugs. Thank you, Dr. Beyene, for sharing your expertise with us today. Please join me in warmly welcoming Dr. Tizazu and Dr. Beyene. Please go on.
Hey, Salam Damnachu. Thank you for having me today. So I'll do the first part, and then Dr. Beyene ደግሞ ከኔ በኋላ መቀጠል ይችላል. Can you guys see this?
Yeah, we can.
Okay. Do you see the whole, do you see my next slides or just one slide at a time?
We see your next slide too.
Okay, let's see then. Not that one. Okay. So I'm going to be talking about epilepsy management with a focus on anti-epileptic medications. Okay, so when I first gave the talk, we talked about how to make a diagnosis of epilepsy. Now we're going to talk about how we are able to treat and manage those patients who continue to have seizures. So in terms of treatment for epilepsy, the biggest thing is going to be anti-seizure medications, especially in Ethiopia. But in other places, we have other things that we can do for these patients, like a vagus nerve stimulator, other types of brain stimulators, resective surgery, and ketogenic diet. In general, the goal is to have no seizures, but also having no adverse effects as well. So when you're first initiating an anti-seizure medication, the most important thing is to have a discussion with the patient about why they're starting the medication. So like I always talk to patients saying you have epilepsy, which means you've had 2 or more seizures separated 24 hours apart. And the risk of having an additional seizure is over 65%. And we would start an anti-seizure medication so that we can reduce the chances of you having another seizure. And always talk about the fact that we don't know if that medication is going to be the one that's going to work, if you're going to need additional medication. So kind of give them expectations, right? So we don't want to go in saying, oh yeah, I'm going to cure your epilepsy with this medication, right? And then the other thing is to speak to them about the importance of the fact that epilepsy shouldn't be limiting. So if they're students, they can go to school. If they're adults, they should continue to go to work. They should continue to play. And then in terms of picking a medication, the anti-seizure medication that you start can be based on the patient's age, um, seizure type, and overall clinical status. And most importantly, in places like Ethiopia, we want to make sure that we're starting them on a medication that they can afford and actually have access to. So the general guidelines for anti-seizure medications is you start with one medication at the lowest starting dose and titrate up slowly. I typically increase at least weekly. Sometimes I do it like every 2 weeks or so. And we do that until seizures are controlled. Um, when you're picking an anti-seizure medication, you want to make sure you know what other medications the patients are on and check for drug interactions. Um, and then you have to go in with the understanding that if you're using more than one anti-seizure medication, there may be effects of one anti-seizure medication on another. And so you have to kind of be mindful of that. You also have to be mindful that anti-seizure medications, especially the older generation medications that are available in Ethiopia, have effects on the liver. And as a result of that, they can reduce the efficacy of hormonal birth control or vice versa, other like immunosuppressant medications, antipsychotics, and some antiretrovirals. So be keeping in mind of all of those issues. And if you need you max out the first anti-seizure medication. If you need to add a second anti-seizure medication, there is some evidence to suggest that picking a medication that has a different mechanism of action might actually get seizures under better control, right? So the best synergism that we know in epilepsy is the combination of Depakote and lamotrigine. So when prescribing anti-seizure medications, again, we talk about the indications. Does this patient meet the criteria to be started on anti-seizure medication? Do they have any contraindications to starting that specific anti-seizure medication? And you must know what the dose range is, how to start, how to taper, how to increase the side effects, and then how to add an anti-seizure medication if needed, or how you go from one anti-seizure medication to another. So in general, the other thing that's important is to talk to patients about side effects and what to expect, right? Because the last thing we want is for us not to have a discussion with them and then they go home and they experience a side effect and they just stop taking it, right? That's not what we want. So I usually give them the highlights of what to expect in terms of side effects. I think it's also important to tell patients that they experience anything new to talk to us about it because when people picked these side effects, right, like they didn't include Ethiopians, right? For the most part, it was done in the Caucasian people. And so we actually don't have any study that tells us exactly what side effects we can experience. So I always, tell patients that, be on the lookout for these more common side effects. But if I have patients who come and tell me a side effect that they're experiencing that is not a known side effect, I always listen to them. And sometimes I switch to another medication if needed because they know their body more than I know their body. In general, the most common side effects in terms of anti-seizure medication is dizziness and drowsiness. Sorry, did anybody? And then Dr. Beyene is going to be telling us more about the specific side effects of the so one thing that I would say is that, you know, to kind of keep track of the birth defect issue with the Depakote, and that if you have a woman who is of childbearing age, they should be on folic acid. The amount of folic acid that they get is going to be different depending on which anti-seizure medication that they're on. So in general, if they're on phenobarb, phenytoin, valproic acid, carbamazepine, that should be 4 milligrams is kind of the recommendation. And then if they're on the Keppra and lamotrigine, then 1 milligram is enough. Okay, now I'll send it over to Dr. Beyene.
Okay. Let me get changing my. Okay. Good. Thanks for having me. እኔም ያው በአማርኛም በእንግሊዝኛም እንግዲህ በጉራማይሌ እየተነጋገርን I'll talk about that. Let me share my screen. 1 second. Okay. Share. Yeah, it's taking a little bit. Oh, yeah, PowerPoint not responding. Let me go back and get it. Control this. I have to go out to this with the system and then come back. 1 second here. Every once in a while, does it? Let's see. Okay, go back. Restart PowerPoint. Okay, let's see. Okay. Itayal. Stop sharing and restart.
ይታይ ነበር ዶክተር። አሁን ሼር እያደረገ አይደለም።
አንድ ጊዜ Okay. ይታያል አሁን?
አዎ ይታያል።
ይታያል በደምብ?
አዎ ይታያል።
Okay, በጣም ጥሩ። So ስሜ የሸዋኔ በየነ እባላለሁ። ፋርማሲስት ነኝ። ዶክተር ሳለም ሜንሽን እንዳደረገችው እና I'll talk about anti-seizure medications. ከዚህ በፊት አንታይ-ኤፒሌፕቲክ ድራግስ ነበር የሚባሉት፣ ግን በአዲሱ ኖመንክሌቸር ኤፒሌፕሲ ኪውርድ የሚሆን አይደለም እና you just take care of the seizures። በዛ ምክንያት anti-seizure medication ነው የሚባለው እና ግን ብዙ ጊዜ ያው ሰርች ስታደርጉ አንታይ-ኤፒሌፕቲክ ማግኘት ትችላላችሁ፣ አንታይ-ሲዥር ማግኘት ትችላላችሁ። So let me go to the next slide. Okay, so these are the general the drugs that are used for treating seizures, and I'll go over the ones that are available in Ethiopia. These are just a general classification of anti-epileptic drugs. From the barbiturates, we have phenobarbital, hydantoin, phenytoin ነው እዚህ ያለው። ሰክሲናማይድ የተወሰክሲማይድ የለም እዚህ፣ ግን ቤንዞዳያዘፒን ብዙዎቹ ይኖራሉ፣ ግን ክሎናዘፓም አለ እዚህ። ፕሪሚዶን አይ ዶንት ቲንክ ያለ አይመስለኝም። ሚኖስቲልቢን፣ ካርባሜዘፒን አለ። ሌሎቹ ሰከንድ ኤንድ ተርድ ጀነሬሽን የሚባሉት ካርባሜትስ የሉም ግን ስለ ካርባሜዝፒን እናወራለን valproic acid ስለሱም እናወራለን lamotrigine is one of the newer agents actually እና I mean ትንሽ ቆይቷል ግን it's a very effective agent I was thinking of levetiracetam እሱ ነው the newer agent እና ስለሱም እናወራለን so እያንዳንዳቸው ትንሽ few 2 or 3 slides ከበር አድርግና ከዛ በኋላ ደግሞ አንዳንድ ጥያቄዎች ተጠየቁ አሉ እሱን ላይ ደግሞ እንትን እንላለን Okay, so this is just a general mechanism of action of all of the anti-seizure medications, you know, and እዚህ ላይ እንደምታዩት እንግዲህ these are postulated mechanism of action የሚባሉት እና in general በብዛት ያሉት anti-seizure medications voltage gated sodium channel blockers ነው የሚባሉት so basically they block the entrance of sodium into the cell and prevent depolarization and reduce action potential እና በዛ ነው ይሰራሉ ተብሎ የሚታሰበው sodium channel blockers እና በብዛት ያሉት እነሱ ናቸው እዚህ ጋር እንደምታዩት ያው ፌኒቶይን አለ ካርባሜዝፒን አለ lamotrigine አለ እነሱ ነው ከቨር የምናደርገው ግን ሌሎችም እንደዛ ናቸው levetiracetam የሚባለው again አለ እና SV2A agonist ነው የሚባለው basically it binds to the SV2A synaptic receptor now prevention of glutamate that's what the mechanism is thought to be እንግዲህ እነዚህ በስተቀኝ በኩል የምታያቸው excitatory synapse ላይ to reduce the excitation action potential ናቸው በስተግራ በኩል ደግሞ የምታያቸው inhibitory synapse ናቸው inhibitory synapse የሚባሉት gamma ወይም gamma aminobutyric acid the inhibitory neurotransmitter ነው basically መድኃኒቶቹ they increase the efficacy of GABA or they increase the half-life of the the neurotransmitters በዛ አይነት ነው ይሰራሉ ተብሎ የሚታሰበው እና በዛ በኩል የምታያቸው barbiturates for the most part እና benzodiazepines እነሱ ናቸው በዛ በጋባ ኤንሃንስ ያደርጋሉ ተብሎ የሚታሰበው same thing with valproic acid as well እሱም በጋባ ነው ይሰራል ተብሎ የሚታሰበው so more inhibitory increasing the inhibitory efficacy of the body ማለት ነው በስተቀኝ በኩል ግን እንዳልኩት excitatory synapse መቀነስ ነው እና so አሁን ወደ እንትኑ እንሄዳለን የሚቀጥለው in general and this is just a general choice of anti-seizure medication and on the paper like በቅርብ ጊዜ የተጻፈ paper ነው and now based on the seizure type what is the common first monotherapy what is the alternative እሱ ከሌለ ወይም ደግሞ ሌላ ምርጫ ከተፈለገ እና what's an add-on therapy ብሎ እንትን የሰጠው እንትን ነው ሬኮሜንዴሽን የሰጡት ሬኮሜንዴሽኖች ናቸው በጣም የታወቁ ዶክተሮች ናቸው ኤፒሌፕቶሎጂስቶች ናቸው የጻፉት እና ግን ከዛ ውስጥ ይሄንን እንትን ማድረጉ ምንም ጥቅም ስለሌለው I just took out the only ones the drugs that are available in Ethiopia እና እነሱን ወስጄ I used the same I made a new chart እና እንደምታዩት ነው focal onset seizure ድሮ partial onset የሚባሉት አሁን focal onset ነው የሚባሉት እና ለfocal onset common first monotherapy recommended የሚደረገው lamotrigine levetiracetam and carbamazepine again እዚህ ያሉት ናቸው እና as a monotherapy alternative valproate phenytoin እና phenobarb ናቸው እና ዶክተር ጸገነት እንዳለችው the recommendation መጀመሪያ you start with a monotherapy እና and if you try one ካልሆነ ደግሞ maybe even another monotherapy ከዛ በኋላ ደግሞ you can do combination therapy እና እነዚህንም combine ማድረግ ይቻላል and then mention እንዳደረገችውም different mechanism of action sodium channel blocker versus GABA እንደዛ combination ቢሆን የተሻለ ነው ተብሎ ይታመናል in general ግን አንዳንዶቹ ደግሞ ቅድም ሜንሽን ያላደረኩት there are some drugs that have multiple mechanism of action እና exactly ይሄ ነው ብሎ እንትን ለማድረግ additional እንትንም አላቸው mechanism of action the next seizure type is general onset tonic clonic seizure grand mal ድሮ ይባል የነበረው አሁን እና ጀነራል እንደዚህ ተብሏል እና common monotherapy valproate እና levetiracetam ናቸው recommended የሆኑት እሱም ካልሆነ ደግሞ monotherapy alternative lamotrigine ልንጠቀም እንችላለን እና you can combine these as well For absence seizure, valproate no recommended የሚሆነው ኤቶሳክሲማይድ አለ ግን ስለሌለ እዚህ valproate is the common monotherapy alternative levetiracetam እና lamotrigine ናቸው። myoclonic seizures ለሱ ደግሞ valproate እና levetiracetam ናቸው recommended የሚሆኑት እና this is again the reference reference ያለው እዛ ነው እና I can share that later on with Dr. Salam. So let's talk about each of the drugs individually. Now we'll start with lamotrigine. Lamotrigine ሌላ ስሙ ለሜክታል ነው ትሬድ ኔሙ ግን ያው በጀኔሪክ ነው እንትን የምንለው እና መጀመሪያ I'll go over the indication for adjunctive therapy ያው additional as an additional ተጨማሪ ሆኖ እንዲጠቅም እንግዲህ ኢንዲኬሽን መጀመሪያ ትንሽ ወደኋላ ልበልና ኢንዲኬሽን ሲባል ፉድ ኤንድ ድራግ አድሚኒስትሬሽን ያን መድኃኒት ካምፓኒው ለፉድ ኤንድ ድራግ አድሚኒስትሬሽን ይሰጥና ኤፊካሲዎቹን ያሳያል እና በዛ ምክንያት በዚህ ኢንዲኬተድ የሚሆነው ለዚህ ሲዥሮች ነው ተብሎ ፍቃድ ይሰጠዋል። ከዛ ውጪ ግን ማስተዋወቅ አይችልም። ዶክተሮች they can use it for anything that they want ግን drug company they can only talk about the indications allowed by the FDA ማለት ነው። ስለዚህ by FDA እንግዲህ እነዚህ ደግሞ by the way የድሮ የቆዩ መድኃኒቶች ስለሆኑ የድሮውን ኖሜንክሌቸር ነው የያዙት። partial onset ያው focal onset የሚባለው primary generalized seizures of Lennox gastae በልጆች ላይ በብዛት የሚታይ syndrome ነው። The other one as a monotherapy recommended now in patients 16 years and older. If physicians want to convert patients on carbamazepine, phenytoin, phenobarbital, and with lamotrigine, they can convert, and it's allowed or it's indicated for that. The other thing is unique Miarago lamotrigine. It's also approved for bipolar disorder. As you know, bipolar disorder, mania, depression, and draw, and now it's been shown to be effective in bipolar disorder. So, some patients depression ካላቸው bipolar depression ካላቸው እና at the same time epilepsy ካላቸው ይሄ ጥሩ መድኃኒት ጥሩ ነው ማለት ነው። በኋላም እንደምናወራው mania እና especially depression common ነው epilepsy ውስጥ ስለዚህ በዛ ምክንያት lamotrigine ይወደዳል ማለት ነው። እና የተለያየ አይነት ፎርሙሌሽኖች አሉ። I think እዚህ ያለው ያው ታብሌቱ ነው for the most part. Mechanism of action we talked about it. Half life in 25 hours no again depending on what kind of drug the patient is taking it could be as low as 13 hours with enzyme inducing anti-seizure medications and or could be 70 hours with valproic acid ደግሞ enzyme inhibitor የሚባለው ነው እና ስለሱ በዛ ምክንያት አሁን ዶዙ ታዩታላችሁ። So lamotrigine dose I'll just start here ከመሃሉ እና in patients not taking the enzyme inducers carbamazepine, phenytoin, phenobarbital or valproate mild they start with 25 milligram every day. ከዛ በኋላ after 1 to 2 weeks the first and second week about 25 milligram ይቆያሉ። ከዛ በኋላ weeks 3 and 4 50 milligram. Weeks 5 onwards, they increase by 50 milligram every 1 to 2 weeks. Now, the usual maintenance dose is 225 to 375. ነገር ግን if they are taking valproate, valproate it's an enzyme inhibitor, no? So it prevents the elimination of the drug. ስለዚህ plasma concentration ይጨምረዋል ማለት ነው እና በዛ ምክንያት ዶዙ ይቀነሳል። So week 1 and 2 25 milligram every other day ነው የሚሰጠው። ከዛ weeks 3 and 4 ደግሞ 25 milligram every day. ከዛ ደግሞ በweek 5 25 to 50 milligram every 1 to 2 weeks የተጨመረ the dose እንደምታዩት 100 to 200 milligram with valproate alone ይሰጣል ማለት ነው እና on the flip side ደግሞ in patients taking enzyme inducers የሚባሉት ለማስታወስ ያህል ማስታወሰው CPPP ነው carbamazepine, phenytoin, ፌኖባርብ and primidone CPPP እነሱ በሙሉ ኤንዛይም ኢንዲዩሰርስ ናቸው እና እነሱን የሚወስዱ መድኃኒቶች ሰዎች ደግሞ because it gets rid of the drug quickly, you have to increase the dose ማለት ነው. So for week 1 and 2, 50 milligram per day ነው. ከዛ ደግሞ week 3 and 4, 100 milligram a day. ከዛ week 5 እንደዛ ያለ ይቀጥላል. It's very important to have a slow titration of lamotrigine. ምክንያቱም fast ከሆነ as you'll see in the next one, there's increased adverse events. And I'll show you that as well. ከዛ በፊት most common adverse events ናቸው እንግዲህ any drug has adverse events ግን ያው the company has to say exactly what happened in 1% or 5% or anybody so it doesn't mean it's going to happen in everybody. There's more common ones and there's less common adverse events ማለት ነው ስለዚህ for example in the adjunctive trials the most common ones were dizziness, ataxia, somnolence, diplopia, double vision የሚባለው እነዚህ very common ናቸው sodium channel blockers ላይ fairly common ናቸው እና usually እየቀነሰ ይሄዳል እንትኑ ማነው severity እየቀነሰ ይሄዳል as time goes on 11% discontinued because of adverse events አንዳንድ ጊዜ በጣም adverse events በጣም high ስለሆኑ people have to discontinue their medication ስለዚህ 11% discontinued ሌላ ስተዲ ደግሞ ሞኖቴራፒ ላይ ተጠናው እንደሚያሳየ ደግሞ እነዚህ ናቸው again some of them are common vomiting, coordination abnormality, dyspepsia, nausea, dizziness and now for various reasons 10% discontinued so 1 in 10 people discontinued ማለት ነው now for example rash 4.5%, headache 3.1%, asthenia or weakness 2.4% and now የተለያዩ ስተዲዎች የተለያየ አይነት ሪፖርት አላቸው ሌላ ደግሞ አጃንክቲቭ ትራያል እንግዲህ አጃንክቲቭ ትራያል ለሞትሪጅን ብቻ ሳይሆን ሌሎች መድኃኒቶች አብሮ የተሰጡበት መድኃኒት ነው ሪሰርች ነው ስተዲ ነው እና እንደምታዩት adjunctive lamotrigine versus placebo, headache 29% versus 19%, so much higher with lamotrigine. Nausea, the same thing, higher no. Ataxia 22%, rash 10%, and now so like I said, አንዳንዴ adverse event ስታዩት በጣም ብዙ እንትን አለ ይባላል ግን this happens in few patients but you have to be aware of it and አንዳንዶቹ the more common ones again Dr. Etsegenet እንዳለችው you have to let them know ቀደም ብላችሁ እንዲህ ሊያደርግ ይችላል እና መጀመሪያ ላይ ከአንድ ሳምንት በላይ ወይም ከሁለት ሳምንት በኋላ ከዛ በላይ ከቆየ let me know አለበለዚያ እንደዚህ ያደርገኛል ብሎ ሰውን መድኃኒቱን ሊያቆሙ ይችላሉ so it's important to manage people's expectation የሚባለው ነገር important ነው this is from the package insert እና very warning no lamotrigine can cause life-threatening serious rashes including Stevens-Johnson syndrome, toxic epidermal necrolysis and rash-related death has been caused by lamotrigine ይላል እና ይሄ ሊሆን የሚችለው አንደኛ additional risk factor especially co-administration with valproate like we said valproate increases the plasma concentration በዛ ምክንያት it can increase the chance of getting these severe reactions also exceeding recommended initial dose of lamictal ያው lamotrigine ለማለት ነው በዛ ምክንያት every week every 2 weeks ነው ቀስ በቀስ ካልተጨመረ በስተቀር በአስቸኳይ ከተጨመረ it could be dangerous and then ደግሞ initial dose ከዛ ደግሞ dose escalation በየሳምንቱ የሚጨምረው so the main thing is ይሄን ብቻ ሳይሆን ሌሎቹ መድኃኒቶች የኤፒሌፕሲ መድኃኒቶች rash if you see any type of serious rash የሽፍታ ምናምን አይነት ነገር ካያችሁ you have to stop it ምክንያቱም it could be very severe የሆነ reaction ሊሆን ይችላል ስለዚህ that has to be you have to stop it እና ፔሸንቶችንም መንገር ያስፈልጋል ሽፍታ ካያችሁ መድኃኒቱን አቆሙና ደውሉልኝ ወይኑና ያያችሁ ማለት ያስፈልጋል that's about lamotrigine የሚቀጥለው levetiracetam ነው levetiracetam ወይም እዚህ ሀገር ኬፕራ ይባላል አንዳንድ ሰዎች ቫይታሚን ኬ ይሉታል ምክንያቱም በጣም is used very very much here in the US እና በዛ ምክንያቱም የተለያየ ነው አንደኛ ጀነሪክ ነው ጀነሪክ ስለሆነ ኮስቱ ሎው ነው believe it or not እዚህም ሀገር cost is very important እና generic drug with 80-90% of the drugs that are given are generics ናቸው እና በዛ ላይ ደግሞ it can be given PO ወይንም IV ሊሰጥ ይችላል and it's also broad spectrum ነው broad spectrum ማለት both ለፓርሻል ኦንሴትም generalized onsetም ሊሰጥ ይችላል በዛ ምክንያት it's not dangerous ለፔሸንቶች in general. The other thing is it's safe in pregnancy. በዛ ምክንያት again it can be used as well. አንዴ ይቅርታ sorry ይሰማል still?
Yeah,
oh ይሰማል በደምብ okay. Okay, just want to make sure. ብቻዬን እያወራሁ እንዳይሆን ቼክ ለማድረግ ነው እና በዛ ምክንያት የቤትራስታም ወይም ከፕራ በጣም is very well used. 25% or so of patients or epileptic patients are on levetiracetam or Keppra. So the indications of levetiracetam is for partial onset seizures, focal onset የሚባለው from 1 month and older. Again, that's the other good thing about levetiracetam. You can use it in young patients as well. It's also, it can be used as an adjunctive therapy for the treatment of myoclonic seizures in patients 12 years of age and older with juvenile myoclonic epilepsy. Also, it can be used with primary generalized tonic-clonic seizures. General onset የሚባለው in patients 6 years of age and older. Mechanism, we talked about it, the SV2A now. And now dosing, you have to look at the package in some detail, but in general, you start in adult patients 16 years and older, 500 milligram twice daily. And then you increase by 500 milligram twice daily every 2 weeks to a recommended dose of 1500 twice daily. The dose is the same in myoclonic seizure. Recommended dose final is 1500 twice daily. Pediatrics 7 to 10 milligram per kilogram, but details you have to look at the package insert. In patients with renal, kidney problem, the dose adjustment is recommended. Again, it's also in the PI. Okay, let me point it out. So next one, sorry. So contraindications, patients who are hypersensitive to levetiracetam because it was DO reaction ለፈጠረባቸው ሰዎች, of course it's contraindicated. Angioedema, anaphylaxis can occur. The one thing እዚህ ሀገር ሁሉ ሰው concerned የሚሆነው Keppra as good a drug as it is behavioral abnormalities ናቸው እና it can cause behavioral abnormalities, including psychotic symptoms, suicidal ideation, irritability, aggressive behavior. Monitor patients for psychiatric symptoms, signs and symptoms. It's very important. And now, studies እንዳሳዩት in adults up to 13% of patients, and in pediatrics 38% of patients versus 6% and 19%, almost double ያደርጋል ማለት ነው. By taking Keppra, the increase in irritability and behavioral abnormalities can double ማለት ነው. ስለዚህ it doesn't happen in everybody, but it's fairly common. ስለዚህ you have to be aware of behavioral abnormalities. እና ፔሸንቶችን መጠየቅ ያስፈልጋል. How are you feeling ካለፈው ጊዜ? How do you feel? Do you have any type of suicidal behavior, suicidal ideation? እንደዛ አይነት ነገር ይታያል ወይ? Worsening depression, again, አንዳንዴ ያው ፔሸንት ፋሚሊውን መጠየቅ ያስፈልጋል እና በዛ ምክንያት በጣም እየጨመረ ከመጣ you may have to stop the drug እና especially in children it's very important እና ቼክ ማድረጉ ጥሩ ነው. Somnolence and fatigue, ያው የድካምና የእንቅልፍ ስሜት again is common in many drugs, ግን especially መጀመሪያ any drug including levetiracetam መድኃኒት በሚጀምሩበት ጊዜ እነዚህ መድኃኒቶች it's good to know patients መኪና እንዳይነዱ ወይም ደግሞ እንደሚያንቀላፋቸው መንገር ያስፈልጋል እና at the same time in addition ደግሞ serious dermatological reaction ቅድም ያልናቸው dermatological reactionዎች እንደነ ለሞትጅን ሌሎም ሳይሆን ግን there's always a chance. Especially there's one reaction called drug reaction with eosinophilia and systemic symptoms when when multi-organ hypersensitivity የሚባል አለ. That can happen. ስለዚህ like we talked about, anytime if you see ሽፍታ ወይንም any type of skin rash, you may need to stop it. እና ሌሎችም እንደምታያት ነው. The other thing, not just with Keppra, but with levetiracetam, with other drugs, withdrawal seizures. እና anytime you want to stop መድኃኒት በማቆም በምትፈልጉበት ጊዜ unless significant side effect ካልሆነ በስተቀር ቀስ በቀስ ነው ማቆም የሚቻለው over weeks. እና እንጂ በአንዴ ማቆም withdrawal seizure ሊያመጣ ይችላል. እና most common የሆኑ ሪያክሽኖች እዚህ እንደምታያት ነው. somnolence, asthenia, የድካም ስሜት፣ በጣም የዊክነስ ስሜት፣ infection, dizziness. In pediatric patients, fatigue, aggression, nasal congestion, and now, as I mentioned, pregnancy, very low potential for toxicity. So it's a good drug for, women who want to have children. The next one we'll talk about is carbamazepine. Carbamazepine, as we talked about, is a sodium channel blocker, but it may have other mechanism of action as well. And it's, of course, it is anticonvulsant, but it's also used specifically for trigeminal neuralgia ለሚባለው በቃ የጉንጭ ላይ ከፊት ላይ ያለ pain, most of you ታውቁታላችሁ as physicians. ለፔን በጣም ኢፌክቲቭ የሆነ መድኃኒት ነው እና it's available in tablets. I guess እሱ ነው for the most part ያለው እዛ ግን also an extended release ይኖራል suspensionም አለ እዚህ ሀገር እዛ የሚኖር እንደሆነ አይመስለኝም. The indications የተፈቀደው partial seizures with complex symptomatology as well as generalized tonic-clonic. So again, it's broad spectrum ነው ለማለት አስቸጋሪ ነው ምክንያቱም in some patients, like it says here, it may aggravate absence or myoclonic seizures. ስለዚህ ሲጀሩ ለማይታወቅ ሰው ለልጆች ምናምን በተለይ ኢኒሻሊ ለመስጠት ትንሽ ከባድ ይሆናል ምክንያቱም it can aggravate these kinds of seizures. ስለዚህ broad spectrum አይደለም ግን እንዳልነው ለፓርሻልም ለጀነራልም ይሰራል. mechanism of action we talked about እና again ቅድም እንዳልኩት እንትን ነው it's a enzyme inducer ነው የራሱንም it has what's called auto induction. so መጀመሪያ ላይ half life ትንሽ ይሆንና በኋላ ግን half life እየቀነሰ ይመጣል. it goes from 25 to 12 እና ምክንያቱም it has auto induction የራሱን enzyme induction እንትን ያደርጋል ማለት ነው. ስለዚህ ሞኒተር አድርጎ ሲጀሩ እየጨመረ ከመጣ you may need to increase the dose. Contraindications, patients with history of previous bone marrow depression, especially cancer patients ከሆኑ bone marrow depression issue ካላቸው ከዚህ በፊት if they have been hypersensitive to the drug, if they have known sensitivity to any of the tricyclic compounds, እና ሞኖአሚኖ ኦክሲዴዝ የሚባሉት መድኃኒቶች አሉ እና የቆዩ መድኃኒቶች ናቸው ከነሱ ጋር አብሮ መስጠቱ it could be dangerous. ስለዚህ it's contraindicated. Warnings, serious dermatologic reaction, ቅድም mention ያረኳቸው TEN, toxic epidermal necrolysis, Stevens-Johnson syndromes have been reported. Again, we talked about rash. You see a rash, you stop. And then it should not be resumed in the future. With you shouldn't be using that in the future. Aplastic anemia. እና granulocytosis ያው የብላድ blood count issue ናቸው እና ሊያመጣ ስለሚችል you have to make sure you follow CDC እና it's bone marrow depression ሊያመጣ ይችላል. Suicidal behavior and ideation, as I mentioned, not just this drug but many drugs as epilepsy. And then in general, the more epilepsy ራሱ it can increase suicidal behavior and ideation. በዛ ምክንያት በየጊዜው መጠየቅ ያስፈልጋል. Usage in pregnancy really is not recommended. Carbamazepine can cause fetal harm ሊያደርግ ይችላል. ስለዚህ it's not really recommended unless you absolutely have no choice to use in pregnant women. Precautions, ቅድም እንዳልነው it can worsen absence seizures. በዛ ምክንያት it's not recommended in those kinds of patients. Patients with underlying heart conditions, it can cause a liver problem. ቅድም mentioned እንደተደረገው it can cause hepatic adverse events, hypersensitivity reaction, and some information to patients. And again, if they see any type of symptoms, signs for a potential hematologic problem, for example, a fever, sore throat, rash, እነዛ ነው የሚጀምሩት። እነዛ የግራኑሎሳይቶሲስ ምናምን ያልናቸው ቅድም በዛ ሊጀምር ስለሚችል እንደዚህ አይነት ስሜት ካላችሁ let me know, stop it, and let me know, come to see me ብላችሁ እንትን ማድረግ ያስፈልጋል። suicidal behavior, as we talked about. alcohol, additive effect ሊኖር ይችላል ከካርባሜዛፒን ጋር and sedative effect ይኖራል። at the same time ደግሞ ሊቨርን አፌክት ስለሚያደርግ alcohol is not recommended. እና dizziness and drowsiness can occur, especially እንዳልኩት መጀመሪያ ላይ you have to let people know to not to use automobiles, not to drive, not engage in potentially dangerous tasks, but ሊያንቀላፋ ስለሚችል ማለት ነው። And now laboratory tests are important, like we talked about, because of all the blood issues that it can happen, it can affect. Complete blood count, platelets, reticulocyte, serum iron should be obtained as baseline, ከዛ በኋላ ደግሞ በየጊዜው መከታተል። ደግሞ basic metabolic panel የሚባለው basic and periodic evaluations of liver function, liver function testoችን ማየት ያስፈልጋል. See if the enzymes are increasing and stuff. Liver damage እንትን ሊያደርግ ስለሚችል. And now, again, if it's given with other drugs, because it's an enzyme inducer, ሌሎችንም affect ስለሚያደርግ you have to be aware of that. ሌላው አንዳንድ ጊዜ again, we talked about the cytochrome P450 inducers. One thing, birth control pill Lyme, it can increase and reduce the efficacy of birth control pills. So if patients are on carbamazepine and birth control pills, በቂ ላይሆን ስለሚችል ሌላ የወሊድ መቆጣጠሪያ መጠቀም ሊኖርባቸው ይችላል የሚለውን ለማለት ነው። Adverse events, for the most part, the common ones are like I said, sodium channel blocker ላይ all common የሆኑት dizziness, drowsiness, unsteadiness, and more sodium channel, but it could also cause nausea and vomiting. Hyponatremia in sodium channel blockers is I wouldn't say very common, but it can happen. So that's why metabolic panel መከታተል የሚያስፈልገው ለሱ ነው። Another signs of hyponatremia can include memory impairment, confusion, weakness, unsteadiness, and which can lead to falls. And then additional adverse events that we talked about, aplastic anemia and so on, that we your skin dimension, toxic epidermal necrolysis. Again, percentage high, you have to be aware of it. Cardiovascular system, especially in those patients already had the problem, so which edema problem, hypertension is common, hypertension, ስለዚህ እሱን አፌክት ስለሚያደርግ እሱን ሁሉ መከታተል ያስፈልጋል ማለት ነው። liver, as we mentioned again, መከታተል ያስፈልጋል። pancreatitis is another known side effect. It happens in a few percentage of patients, but you have to be aware of that, and so on and so forth. Dosage, again, that's a big one. I'm not going to go over all of it, but in general, if you just look at the adult population, you start with 200 milligram twice a day, and then subsequent dose, you can go up to 200 milligram per day, per day at weekly intervals. You can give it, TID or QID. Again, extended release ከተገኘ. And now the final dose is anywhere from 1200 to 1600 in some patients, but mostly 1200 is more common one. And then for trigeminal neuralgia, those which are package in subtle ማየት ይቻላል. Okay, still ይሰማል አይደል?
ይሰማል።
Okay. So የሚቀጥለው ፊኖባርቢታል ነው። Again, a very old medication ነው። በዚህ ሀገር ብዙ አይጠቀሙበትም። ሞስትሊ የሚጠቀሙት actually ለስታተስ ኤፒሌፕቲከስ ለሚባለው IV medication በአዘን IV ነው የሚጠቀሙት። ኤመርጀንሲ ሩም ነው for the most part የሚጠቀሙት እና but in general it's a very effective agent as well. So in addition to being a sedative, it can be used as for treatment of generalized and partial seizures. And now, contraindications እንደምታዩት ነው። hypersensitivity, any type of ከዚህ በፊት reaction ከፈጠረባቸው it shouldn't be used. Porphyria የሚባል አለ. Basically it's a rare rare disease ነው, የብላድ issue ነው. እንደዚህ አይነት ፕሮብሌም ካለባቸው it shouldn't be used. In patients with liver function, የሊቨር ችግር ካለ ወይም respiratory disease in which dyspnea and obstruction is evident, it shouldn't be used. In general ደግሞ ያው it's habit forming. Again schedule የሚባላል, schedule 4 ነው እዚህ ሀገር ብዙ አብዛኛው መድኃኒቶች actually anti-seizure medications እንደ habit forming ነው የሚታዩት እዚህ ሀገር for some reason, እና schedule 3 to 4 ናቸው በብዛት. Usage in pregnancy, they can cause fetal damage. በአሁኑ ጊዜ by the way, just as an aside, በፊት በኤፍዲኤ በተለይ ABCDX የሚባል categorization ነበር. አሁን ግን እሱ ቀርቷል እና የፕሬግናንሲ ኢፌክት ለማየት actually you have to go into the package insert and see ምን አይነት ኢፌክት እንዳለው የተጻፈውን ማንበብ ነው። እና በአንድ በኩል ከበድ ያደርገዋል፣ በሌላ በኩል ደግሞ ኤግዛክትሊ ምን ሊሆን እንደሚችል ይናገራል። ግን እንደ በፊቱ አሁን አይ ቲንክ በፊት ባርቢትሬትስ ሲ ነበር፣ አሁን ግን there's no ABC የሚባለው ቀርቷል። just as an FYI. In pediatric patients, it has been associated with cognitive effects. የጭንቅላት ችግር ሊፈጥር ይችላል. And again also because it's a sedative, alcohol ጋርና with other CNS depressant, it can have additional CNS depressant effects. Additional information about phenobarbital, I think እዚህ ሀገር ያለው ታብሌት እናንተ ጋር ያለው ታብሌት ነው፣ ግን ሌሎችም አይነት አሉ፣ አይቪም አለ እና as I mentioned focal onset and generalized ነው. We talked about GABA inhibitory binding, በዛ ነው የሚሰራው. And dosum 600 to 200 milligram a day now. Adult maximum on the package insert 240 milligram daily. That's one thing. Again, ቅድም እንዳልኩት ማቆም ካስፈለገ it has to be tapered, or ቀስ በቀስ ነው ማቆም የሚያስፈልገው። ምክንያቱም ባኔ ማቆም እንትን ከተባለ withdrawal ሊፈጥር ይችላል እና additional conversion ሊያመጣ ይችላል፣ seizure ሊያመጣ ይችላል። ስለዚህ slowly taper phenobarbital as well as any other drug unless you have a severe adverse event. Serum level 15 to 45 microgram ነው አንዳንድ ጊዜ. You can do serum levels many drugs depending, especially if so አንድ ሰው ይወስዳል አይወስድም የሚለውን ለማወቅ ከሌሎች መድኃኒቶች ጋር ሲሰጥ ሌቭሉ ይቀንሳል ይጨምራል የሚለውን ነገር ለማየት አንዳንዴ serum level መውሰድ ያስፈልጋል፣ ግን it's not always necessary. I don't know ይቻልም እንደሆነ እዛ አላውቅም። Adverse events, the most common one as mentioned ያረኳቸው ናቸው. Sedation, cognitive headache, depression, and so on. እንደምታዩት ነው again በጣም ብዙ ነው፣ ግን it doesn't mean that's going to happen in everybody, but you have to be aware of them. Contraindication, warning, and precautions ቅድም mention ያረኳቸው ናቸው. Stevens-Johnson's toxic epidermal necrolysis እና the DRESS syndrome የሚባለው drug reaction with the eosinophilia and systemic symptoms, rash, angioedema, እነሱ ማወቅ ያስፈልጋል. Do not use an hepatic encephalopathy, የሊቨር ችግር ያለባቸው ሰዎች in general, or porphyria ቅድም mention ያደረኩት. Again, phenobarbital is also a enzyme inducer. ስለዚህ ከሌሎች መድኃኒቶች ጋር ሲወሰድ it can reduce the efficacy of the other drugs. So including phenytoin, lamotrigine, oral contraceptives, warfarin, corticosteroids, and many other drugs. የእነሱን efficacy ሊቀንስ ስለሚችል you have to be aware of that. Again, monitoring of CBC እና metabolic panel monitor ማድረግ ያስፈልጋል. Valproic acid የሚቀጥለው ነው. Valproic acid, the indications, monotherapy and adjunctive therapy for complex partial seizures. ያው ቅድም እንዳልነው focal onset with impaired awareness የሚባለው ነው. It can also be used as a sole in adjunctive therapy for simple and complex absence seizures. Adjunctive therapy in patients with multiple seizure type that includes absence seizure, which is a good thing. ቅድም mention አድርጌዋለሁ. Again, in the mentioned in the lamotrigine, it can be used to treat manic episodes related to bipolar disorder, manic depression. More on the mania side, I think bipolar 2 ሚሉት ነው እና ለሱ መጠቀም ይቻላል። So patients already እንደዛ አይነት ችግር ካለባቸው additional benefit ነው። Also, it can be used to prevent migraine headache. So epilepsy እና migraine ያለባቸው ሰዎች valproic acid እንትን ነው ጥሩ ነው። Mechanism of action we talked about, it works through the GABA. Dosage and administration, again, እንደምታዩት ነው 10 to 50 milligram per kilogram per day, increasing at 1 week by 5 to 10 until seizure control or limited side effect. Safety of doses above 60 milligram per kilogram per day is not established. And these are the dosage forms. 250 milligram. It also comes as a syrup as well. I don't know, is available in Dona. Contraindications, እንደምታዩት ነው hepatic disease, የliver disease ችግር ካለ known mitochondrial disorders, rare genetic disorders ናቸው። እንደሱ ካለ ፖልግ የሚባል እንደሱ አይነት ፕሮብሌም ካለ it's contraindicated. Warnings and precautions. Couldn't mention argola hepatotoxicity. It can cause hepatotoxicity, birth defects. And the doctors are going to mention that valproic acid is known to cause birth defects. But it's not recommended to use in women of childbearing age. But young women shouldn't be using that. The other one is pancreatitis. But also it can cause, suicidal behavior, the DRESS syndrome that we mentioned, adverse reaction greater than 5%. So these are abdominal pain, alopecia, amblyopia, blurred vision, amnesia. ብዙ ናቸው እንደምታያቸው እና very effective drug ነው, but at the same time ደግሞ adverse event ሊሆን ስለሚችል አትሊስት ኮመኖቹን መንገር ያስፈልጋል። እንዲህ ሊያደርግ ይችላል። ስለዚህ በጣም ካስቸገራችሁ ንገሩኝና ወይም come and see me ማለት ያስፈልጋል። Drug interactions, as I mentioned earlier, it's an inhibitor ነው, but also other drugs, inducerዎችም ደግሞ የእሱን ኤፊካሲ ሊቀንሱት ይችላሉ። እና important to see the efficacy of these drugs with and without other drugs. Also, co-administration of valproate can affect the pharmacokinetics of other drugs. Diazepam, ethosuximab, and lamotrigine, by inhibiting it can increase their plasma concentration. We talked about pregnancy, major malformation, congenital malformations. It's not recommended. In pediatrics, higher risk of fetal hepatotoxicity. Geriatric, reduce starting dose. Increase dose more slowly and monitor fluid and nutritional intakes. In general, older patients, usually in the stroke, stroke usually epilepsy in the old elderly patients, which የሚታየው እና in those patients, ዶሱን ቀስ በቀስ ነው መጨመር የሚያስፈልገው because they are susceptible to adverse events ማለት ነው። Phenytoin, I think this may be my last one. So phenytoin, the indication is tonic-clonic or grand mal የሚባለው በፊት psychomotor temporal lobe seizures. Also, it's also indicated in prevention and treatment of seizures occurring during or following neurosurgery. ብዙ አይነት neurosurgery አሉት እና ዶዙም እንደምታዩት ነው 3 to 4 milligram per kilogram per day. The maintenance dose is anywhere from 200 to 500 milligram in single or divided doses. Immediate release ስለሆነ divided doses መሆን አለበት እዛ ያለው. Infants and children, the maximum 5 milligram per kilogram per day, maximum is 300 milligram per day, and the daily maintenance is 4 to 8 milligram per kilogram per day. And contraindication, again, if patients have taken phenytoin and have had hypersensitivity, you have to stop it. Increased other hydantoins, history of prior hepatotoxicity, co-administration of delaviridine as an antiviral, no. I don't know if it's available there. Contraindicated, no, kasuga. Warnings and precautions. It can precipitate status epilepticus. withdrawal በሚደረግበት ጊዜ. So whenever you withdraw phenytoin or other drugs, as I mentioned before, do it slowly. That's the best thing. Suicidal behavior in ideation, ቅድም እንዳልነው ነው. Serious dermatologic reaction, again, common ናቸው እነዚህ in many of these drugs, so you just have to be careful. Dress syndrome, the same thing. Cardiac effects, it can bradycardia, angioedema, and the zoo, hepatic injury can happen. And then hematopoietic complications as well. More adverse reactions, CNS depression, ቅድም እንዳልነው, residual sedation or hangover, drowsiness, lethargy, እና እንደምታዩት ናቸው ከማንበብ. I'll just let you look at it. It's good to look at the percentage, and those adverse reactions that can happen in 1 in 100. Again, nervous system, agitation, confusion, respiratory system, cardiovascular system, so it doesn't happen in everybody. The most common one, as you can see, is somnolence, which is again common in many of these drugs. Drug interactions, so already አስምሮልኛል ነው እኔ ሆነኝ ያደረኩት. Extensive plasma protein binding, it also goes through saturable metabolism and potent induction. ቅድም እንዳልነው, it's an enzyme inducer. በዛ ምክንያት it can reduce the efficacy of other drugs. Pregnancy, fetal hydantoin syndrome, ሰምታችሁናል. It can cause that, so it's not safe. And then also in renal and hepatic impairment, you have to monitor unbound phenytoin concentration. I don't know if it's available, it's difficult to monitor anyways. So ዋናው ፕሬዘንቴሽን እዚህ ላይ አቆምና አሁን አንዳንድ ጥያቄዎች ዶክተር ሳለም የላከችልን አለ. You want me to go ahead and discuss this, Dr. Etsegenet, and then you can do your questions?
Yeah, that's fine.
That's fine? Okay. So the first question was about sexual dysfunction in anti-seizure medications. So the question was, a 30-year-old male with well-controlled epilepsy in phenytoin, on phenytoin and phenobarb, reports erectile dysfunction and low libido. So the question is, could the anti-seizure medications be the cause? Could switching to carbamazepine or lamotrigine improve symptoms? So I thought in general, sexual dysfunction in anti-seizure medication, አንዳንድ ነገር note እንትን ብያለሁ እዚህ ላይ. እና the one thing is sexual dysfunction is common in patients with epilepsy. And as it says here, nearly 50% of men and women with epilepsy have sexual dysfunction. ግን ያው ትንሽ አሳፋሪም ነገር ስለሆነ ፔሸንቶች ሜንሽን ላያደርጉ ይችላሉ፣ ግን very common, 1 in 2 ማለት ነው. Now, if you look at various studies, the prevalence is different. ምክንያቱም the way they do the studies, the way the kind of patients that they have, the number of anti-seizure medications, how well controlled, all of those things matter. እና በዛ ምክንያት you can see the difference in the prevalence of sexual dysfunction with anti-epileptics. So in general, though, in patients with uncontrolled epilepsy, epilepsy very well controlled, those patients with a long duration of epilepsy, focal epilepsy, higher seizure frequency, and those receiving enzyme inducing anti-seizure medications are more likely to have sexual dysfunction. Okay, እነዛ መድኃኒቶች ቅድም ያልናቸው CPPP ያልናቸው carbamazepine, phenytoin, phenobarb እና primidone. And even women can have dysfunctions in domains of desire, domains of desire, whereas males have disorders such as erectile dysfunction and premature ejaculation. Depression and anxiety contribute to sexual dysfunction in persons with epilepsy. And the way that enzyme inducers cause sexual dysfunction is thought by it affects the metabolism of the gonadal steroids. ኤስትሮጅንም ሆነ ቴስታስትሮን የእነሱን ሜታቦሊዝም አፌክት በማድረግ ነው ይህንን ኮዝ የሚያደርጉት. So to answer the question, limited data suggests that newer anti-seizure medications, including oxcarbazepine, lamotrigine, which is a question here, and levetiracetam cause no or minimal sexual dysfunction. So in general, lamotrigine and levetiracetam are probably good to use in sexual dysfunction, in patients with sexual dysfunction. So this person can probably benefit from using lamotrigine or levetiracetam. That was the answer. The next one is anti-seizure medication. Specifically, do anti-seizure medications milk does it affect ያደርጋል ወይ? What is the interaction of most drugs such as sodium valproate with milk and other foods? It's difficult to find information specifically with anti-seizure medications and milk, but in general, I found a lot of information about just general foods and anti-seizure medication. Now, these are small studies that have been done to look at this issue. For example, in this patients only, there were like how many people? Eight healthy volunteers. Food appeared to accelerate absorption of the drug. Peak concentration was significantly higher. So peakun ሊጨምረው ይችላል. So maybe adverse event ሊጨምር ይችላል ነው የሚለው. Last study looking at effect of carbohydrate, fat, and protein on phenytoin absorption. Again, only 10 patients. It really didn't have any effect. Protein may decrease the absorption of phenytoin. So it's not doesn't seem to have a very high effect of food in phenytoin. Another one is sodium valproate. In 6 healthy volunteers, food intake was delayed, but did not decrease the extent of absorption of valproate from an enteric-coated formulation. So although delayed ቢያደርገው, in the end, patient got what they needed to get ማለት ነው. Another study looking at levetiracetam, really rate and extent of absorption of oral levetiracetam were not significantly impaired. So ምንም ችግር የለውም levetiracetam መስጠት ነው. So in this is from, by the way, Epilepsy 2024 now, this information. And now they have a general guideline on anti-seizure medications and food. Carbamazepine, it says administer with meals or with large amount of water to minimize gastrointestinal adverse events in Milo. Serum levels may be increased with grapefruit or pomegranate juice. Now, juice is a common name. And anyways, grapefruit, I don't know many common in Doana, which pomegranate, Roman, I think in Yagar Mibalo, and it can increase that. Lamotrigine administered without food, no recommendation. Tablets must be swallowed whole and must not be chewed, crushed, or divided. Levetiracetam, as we mentioned, it doesn't have any, it can be taken with or without food. Phenobarbital may be taken with or without food, doesn't have really much effect on the Milo. Phenytoin may be best to administer on an empty stomach or in a consistent manner in relation to food to avoid bioavailability problems. Valproic acid may be administered with food or with a large amount of water to minimize gastrointestinal irritation. That's the recommendation. A final question. So most epileptic patients taking tramadol as an anti-pain experience a lower threshold of seizures. What are the commonly used medications but are contraindicated in epilepsy? And a lot of drugs that are used for the common cold do lower the seizure threshold. For example, diphenhydramine, Benadryl, so active agent Benadryl and other medication used to treat allergies or cold. These are drugs to avoid in epilepsy. Pseudoephedrine, decongestant, as you guys know. Any Sudafed no common, Zamandona lagam, and not any allergy medication with a D at the end. Pseudoephedrine አለው ማለት ነው። ስለዚህ you have to be careful with those drugs. They can lower seizure threshold. Bupropion, I don't know ምን ያህል ኮመን እንደሆነ ለዲፕሬሽን እና ሌሎችም ነገሮች ይጠቀሙበታል. It can lower tramadol. አሁን ሜንሽን የተደረገው መድኃኒት it definitely can lower seizure threshold, and now it may be best to use another kind of pain medication. Oral contraceptives, as we mentioned, can be taken, but the efficacy may be reduced significantly. በዛም ምክንያት it's best to use another kind of birth control pill. እና certain antibiotics, I think የመጨረሻው እንትን እዚህ ላይ ያሳያል. Antibiotics, drugs shown to lower seizure threshold, cefepime, imipenem, unison የምታያቸው ናቸው። Antipsychotics, clozapine, chlorpromazine, antidepressants, bupropion, buspirone, venlafaxine, and then all the tricyclic antidepressants, as well as lithium. Analgesics, again, fentanyl, tramadol, the one that questioned, meperidine, Demerol, commonly used, and now immunosuppressants. They are the ones who are recommended to avoid in patients with seizures. So I think that was the last one. I don't think, I think it's got. Thank you for listening. Let me stop sharing.
All
Okay,
right, thank you,
thank you so
Doctor.
much
That was
for your
very
attention.
insightful. Would you wait for us until the end of the presentation, or you want to leave?
Sure.
You'd stay?
I talk a lot about something, but okay.
Okay, so going back to my talk. Thank you, Dr. Beyene. That was very insightful and very informative. So now that we have that background, what happens if the seizures continue? What do we do? So you always maximize the first agent. If the seizures get worse or there's no response despite increasing the dose, you have to reevaluate. Are you treating seizures to begin with? Are they non-epileptic events? Or are you are they experiencing some sort of side effect, or are they just not taking the medication the way that they should? And once the first medication has been maximized, then you can talk about, or you can think about adding a second agent if needed. And then the most important thing is you only make one change at a time, and you have to actually give some time, right? So if you see a patient on Monday, seizures continue, you increase the medication on Monday, they call you or they come to the clinic on Thursday and they say, I'm still having seizures. You don't make any medication changes, right? Because on average, anti-seizure medications need at least, 2 weeks to a month to reach a therapeutic level once you make a medication change. So, be patient, reassess, and just make one change at a time and give it time. So as you all know, up to 70% of patients who have epilepsy will become seizure-free on the first anti-seizure medication. But that means that the remaining 30% will have what we call drug-resistant epilepsy. So one study that came out in 2012 showed that with the first anti-seizure medication, there is about a 50% chance of becoming seizure-free. If you need a second anti-seizure medication, the chances of seizure freedom is 13%, and then it goes lower to 3.7% after the third seizure, and then 1% after each additional drug that's tried. And this is a persistent thing that we see despite having an increased number of anti-seizure medications. So what can we do? So again, I'm going to state that you start with the first, maximize, and then add a second agent if available. If seizure persists, then now the patient is essentially diagnosed with drug-resistant epilepsy. So at that point, what do we do? So in this part of the country, that would be the point where we talk about pre-surgical evaluation. So sending them to a surgical center where they can be considered for epilepsy surgery or devices. Now, that would be also a time to consider ketogenic diet. I think given the limitations that we have in Ethiopia, maybe that, if the patients are not taking medications that is right for the type of epilepsy that they have, or if there's newer anti-seizure medications, for instance, if someone is taking phenytoin and they are not seizure-free, you can consider trying them on levetiracetam or other anti-seizure medications, or doing the combination of the medications with different mechanism of actions to try to see if you can get them under better control. I do believe that there are some centers who actually do epilepsy surgery in Ethiopia, so that might be a time to kind of reach out to the community and find people who may be able to offer them surgical options. And just to back up, the surgical options that I'm talking about specifically for Ethiopia are for people who have drug-resistant focal epilepsy. The people who have drug-resistant generalized epilepsy are most commonly you can get devices, and there are some things that you can do, but I think that's more of a specialized center that happens typically on this side of the world. The most important thing is the quality of life is the most important thing for families, for patients, and it should be for us as well, right? So in drug-resistant epilepsy, you have to discuss the side effects of each of the medications and then balance that with seizure freedom, right? So when you see a patient who is on 3 or 4 anti-seizure medications, if they can't lift their head, if they can't smile, eat, talk with their parents, interact with people, then you should, try to see what the parents and what the patient is okay with, right? So we always say you treat the most severe seizures first, right? So if you have a patient who has Lennox-Gastaut, for instance, and they have bilateral tonic-clonic seizures, they have tonic seizures, they have myoclonic seizures, subsidence seizures, we focus on the seizure that's going to lead to an increased risk of injury, right? Like, so if they have atonic seizures or the drop seizures, we definitely want those under control, right? We also want the bilateral tonic-clonic seizures under control. But if they have, nocturnal tonic seizures that kind of happen multiple times in a day, and we have a hard time controlling that, I would not necessarily change the medication, right? So just, thinking about treating the most severe seizures and then being okay with tolerating some seizures to kind of balance with the side effect and increasing the quality of life. So now on the opposite side, so what happens if you have a patient that you start on a medication and they're seizure free? When do you actually consider discontinuing anti-seizure medications? So when you consider medication discontinuation, we typically recommend patients have to be seizure free for at least 2 years. There's some studies that looked at what the difference is in terms of seizure recurrence between patients who've been seizure free for 2 years versus seizure free until up until 5 years, and there really is no significant difference. So that's kind of the minimum is seizure free for at least 2 years, and this includes all types of seizure types, and this includes auras too, because auras are focal aware seizures, right? And so if patient's seizure free for 2 years, you have to consider other factors like how long have they had epilepsy? What types of seizures did they have? Did they require multiple anti-seizure medications? Did they have multiple bouts of status epilepticus? Because those things have been associated with increased seizure recurrence. If a patient has a known structural lesion, that also is associated with higher risk of seizure recurrence. And then patients with certain epilepsy syndromes, right? You would never wean a medication off for someone who has Lennox-Gastaut, for instance, right? And then patients who have idiopathic generalized epilepsy have a less likely chance of remaining seizure-free once anti-seizure medication is continued. And that's specifically true for patients who have juvenile myoclonic epilepsy with an 85% recurrence risk. So taking all of that into consideration, then you would talk to the patients about the pros and cons and decide how to proceed. In general, children have a lower relapse rate than adults, and depending on the epilepsy type and etiology, about 11 to 41% of patients will have seizure recurrence after they been weaned off of anti-seizure medication, and the most relapse will occur within the first 1 to 2 years. Now, in terms of do we do an EEG to decide what to do or to wean off of anti-seizure medication? So for the pediatric population, we know that seizure recurrence is higher for children who have epileptiform activity on EEG. There's also other studies that says it's not necessarily the epileptiform activity, but if you see focal slowing, that also is associated with increased chance of seizure recurrence. So in some pediatric populations that might be something that's worth doing. There is no data available for adults in terms of whether or not an epileptiform activity on the EEG or focal slowing is indicative of increased seizure recurrence. I can tell you in my practice, I definitely do EEGs, but that's because EEGs are kind of readily available. But one thing to note is that if the EEG is normal, the risk of recurrence is still the same, right? It only helps if it's positive. And I'm sure, as Dr. Pollard pointed out, EEG is not a perfect test, and it's only positive approximately 50% of the time. So once you make the decision of discontinuing the anti-seizure medication, how do you actually do it? So never discontinue an anti-seizure medication. You just don't stop it because that can lead to, that increases your risk of status epilepticus. So the way I like to approach it is I wean the medication that I know is the least effective medication or the one that has the most bothersome side effects first. I always wean. So typically no more than 25% of the dose in a given week. So most medications will take over a month to wean off. Phenobarbital is the exception and should be weaned off at least over a period of 6 months because there is an increased risk of status epilepticus with the phenobarbital wean. If patients are on polytherapy, I would wean one medication at a time. I would monitor for seizure recurrence for 3 to 6 months. So say a patient is on Keppra and Depakote, so I wean the Depakote off first. I would probably wait at least 3 to 6 months before thinking about weaning off of the Keppra. And like I said, if they're seizure-free, then you can proceed with weaning the additional medication. Okay, so Salem sent me a few cases to go over, so we can go over those cases now. So the first one is a 13-year-old boy who has bilateral tonic-clonic seizures for the past 5 years, with some improvement on phenytoin after 2 years of treatment. Then the family decided to discontinue the medication. And then this patient began to have some abnormal movements of his face and upper extremity. They restarted the phenytoin, but the abnormal movements could not be controlled. And then this patient had an EEG that showed multiple generalized epileptiform discharges. So before we get to the discussion, I'm going to show you the types of movements that the patient has. Let me know if you can see it. Are you guys able to see it?
Yes.
Okay. I don't think we need to watch the whole video, but you kind of got the gist. And then this is his EEG. It's kind of unclear from what I can see, but so far what I'm saying is I can just describe what I'm seeing. So first, going back to the movements that this little boy was having, I would classify this as just, myoclonic jerks. They are very brief, involve kind of like the head, the bilateral upper extremities from what I can see. He also, to me, obviously I have never met him. I don't know his background or anything like that. But he seems kind of sedated and out, like basically not attentive. And then the EEG, so far from what I'm seeing is that there is no PDR. So I would categorize this as, generalized background slowing. In addition to that, I am seeing some areas, like I said, is very blurry, where I would call probably multifocal discharges. There are some areas kind of in the bifrontal regions that are where I see discharges, and then there are other generalized discharges that I'm seeing as well. So we can continue to see some of these. What would be interesting is to see if when he's having the generalized discharges, if those are lining up or if they're correlating with the myoclonic jerks that he's having. Salem, do you know if that's true?
Yes, doctor, they were correlated with the myoclonic jerks.
Okay. All right. So I think we've seen enough. Salim, can you give me more information about the patient? Does he have, in addition to the myoclonic jerks, does he have any other seizure types? You said the generalized tonic-clonic seizures, but does he have absence or like tonic or atonic seizures?
So the seizures were generalized tonic-clonic seizures 2 years prior to this incident, And then after discontinuation of the phenytoin, it started to become myoclonic, just like this one.
Okay. So the question is, in this patient, what is the preferred first-line anti-seizure medication? So, and then what alternative exists if sodium valproate is unavailable? And then what drug is preferred for individuals who have absence and myoclonic seizures. So phenytoin is effective for focal seizures as well as bilateral tonic-clonic seizures, but it is not effective against absence seizures and myoclonic seizures. So for this patient, I would wean him off of phenytoin and put him on valproate. Because valproate is broad spectrum, meaning that it works for all of the seizure types actually, compared to phenytoin that is a narrow spectrum and typically is reserved for focal seizures and bilateral tonic-clonic seizures.
Doctor, however, sodium valproate is very, it's not available in our country that much due to the cost and other reasons. So if it's not sodium valproate, what other option do we have?
I would go with all of the options that we have. So you're saying, I mean, I'm assuming you're saying that the Keppra is probably going to be less available compared to valproate then. So I would probably go with phenobarb over phenytoin because it is broad spectrum. And then the only thing with phenobarb is that you would have to kind of be mindful of worsening in absence seizures. But that would be how I would approach it. Obviously, if we can get lamotrigine and Keppra, those two medications, I would much prefer over phenobarbital. I would avoid carbamazepine for the same reason, which is that it's a narrow spectrum.
All right, thank you.
Okay, case 2 is a baby with perinatal asphyxia developed seizures on day 1, which resolved after 48 hours of treatment with phenobarbital. Now he's seizure-free at 4 weeks, and EEG has been normal. So should we discontinue phenobarbital now, and what are the risks of long-term epilepsy? So he's seizure-free, so I would discontinue the phenobarbital, especially in the setting having a normal EEG. The risk of long-term epilepsy is going to depend on what type of chronic or if any chronic damage has happened in the setting of the perinatal asphyxia, right? So I would definitely neuroimage this patient at some point, and then continue to follow the patient. So if there is no evidence of perinatal stroke or any epileptogenic foci, then the risk of long-term epilepsy is likely lower, and it would be higher if there is any structural abnormality. Case 3 is a 12-year-old girl with focal epilepsy, seizure-free for three years on carbamazepine, now has a normal EEG and neurological examination. Is it appropriate to taper and stop the anti-seizure medications? What's the safe protocol? I think we kind of touched this when I was discussing it earlier. So if she's seizure-free, she's more than seizure-free for 2 years, certainly can be weaned off of anti-seizure medication. And like I said, I would wean it off over a period of at least 1 month, 25% each week. Case 4 is a 16-year-old man with focal seizures on phenobarbital, has partial improvement, but the maximum tolerated dose has been reached. So what is appropriate to add a second agent? How do we transition between ASMs safely? So I think I also addressed this during my previous slides, but if you've reached the maximum tolerated dose of the phenobarbital, then it is appropriate to add a second anti-seizure medication. And then just here, I would just recommend being mindful of drug-drug interactions, since phenobarbital is an inducer. And so I guess here, some people believe that if you're going to switch from one anti-seizure medication to the other, you should stop the first one first. I never do that. If I'm going to wean a patient off, say for instance, they're on a medication, it's not working, I want to switch to another medication, I always start the second anti-seizure medication, see if they can tolerate it, and then wean the other one off. If that's something that is able to be done. If not, then I would add the second drug on top of whatever they're taking, especially if their seizures are not well controlled. And then if they're experiencing side effects because of a medication interaction, then I probably would lower the medication that I think is working the least. Case 5 is a 22-year-old man with on phenytoin, has monthly seizures with drowsiness and cognitive slowing. So what is classified as good seizure control? And what should be done next? So the first thing I want to point out is that phenytoin has this really interesting thing where it can cause paradoxical worsening of seizures if the patients are toxic on it. So if the level is super therapeutic, right? So first I would check for that. And then again, with the levels being high could also be associated with drowsiness and cognitive slowing. The other thing is anytime a patient has drowsiness and cognitive slowing that's worse, the first question we should ask is, are these patients seizing more than what they know, right? So you can have subclinical seizure. So this probably would be a patient that I would do an EEG on to see if they're having kind of varifocal seizures or seizures that are not being reported. So that would be probably the first step. In terms of what's considered good seizure control, it depends on the patient, right? So for me, obviously, and probably for the patients, if you have 0 seizures, that would be fantastic. But sometimes that's not possible. And we have to kind of, balance seizure freedom with side effects, as I stated. In terms of what's considered good seizure control, so like I previously stated, good seizure control is where we can get the patients free from seizures that cause them injury or ongoing brain damage. So like the bilateral tonic-clonic seizures or focal seizures that are associated with impaired awareness. And, I can live with patients reporting deja vu every now and then. So I think it just kind of depends on each patient. Just going back to him, if he's on the maximum dose of phenytoin and it isn't working, you could consider something like carbamazepine in this case, right? Because it's a narrow spectrum since he has, I'm assuming he has focal epilepsy. Case 6 is a 5-year-old boy, has absence seizures, was started on phenytoin, now worsening. So we kind of talked about this. So phenytoin can worsen myoclonic seizures and absence seizures. So certainly would recommend switching to something like lamotrigine, sodium valproate, or phenobarbital. Case 7 is 30-year-old man, has generalized tonic-clonic seizures, had good control on phenobarb, but now is not able to find the medication. So it was changed to phenytoin, which has less control of the seizures. So kind of going through the same thing, right? So the question is, did we pick the right medication for this patient, right? So, I mean, phenytoin does work against tonic-clonic seizures, but if the patient has generalized epilepsy, then phenytoin is going to be less effective than other medications. So if he's not able to do phenobarb, I would certainly try to do something like valproate, Keppra, or lamotrigine. I would probably avoid carbamazepine in this patient if possible. And case 8 is an 8-year-old child, has spastic cerebral palsy and daily focal seizures on phenytoin, clonazepam. Seizures persist. So what should we do? So this is a patient who has drug-resistant focal epilepsy, right? So at this point, you should think about which of the medication is working. Is it the clonazepam that's working better, or is it the phenytoin? And then try to decide if you want to add a medication on top of everything that he's doing and keep him on 3 anti-seizure medications, or wean him off of the one that's least effective, right? But this is a patient that could be on any of the medication. So Keppra is good for all of the seizure types. Sodium valproate is good for all of the seizure types. He also has focal epilepsy. So really any of the anti-seizure medications would be appropriate in this case. Okay. I think that's all I have. We can take questions right now.
Okay, doctor. There are questions written in the chat box, so we will go on them one by one. So the first question says, it is well known that liver function should be monitored every 6 months in individuals taking sodium valproate. Should similar regular monitoring, such as complete CBC, also be conducted for patients on carbamazepine?
Yeah, so I answered this question in the chat already, but so for essentially all of the anti-seizure medications that we use in Ethiopia, with the exception of Keppra, I definitely would recommend monitoring liver function tests and a CBC every 6 months if possible.
So the next question is, do you advise initiating levetiracetam for a patient who already has psychotic symptoms?
Good question. So we have a saying in neurology where we say, if you don't know what's happening, give them steroids, and everybody deserves steroids kind of thing. And I feel the same way about Keppra because it's such a fantastic and effective medication. I believe that if a patient wants to be seizure-free, which is all patients, then it's worth trying Keppra. That being said, if a patient has, aggressive behavior, bipolar disorder, that's not managed, that's not treated, then definitely don't do Keppra. But if they're on medication for it and it's well managed, then I don't see any reason not to do Keppra. I think on this side of the world, like we probably have at least 99%, close to 100 patients who try Keppra at some point just because of how effective it is. And the majority of patients do well, meaning, they don't have the psychiatric or the irritability side effect that we typically see kind of like in the literature.
So Dr. Blaine has another question. We usually run out of medication and often abruptly switch medications. For example, changing from sodium valproate to 200 milligram or carbamazepine, 1,800 milligram to other anti-seizure medications. Sodium valproate is 2,000. When starting a new drug like phenytoin, should we begin with the lowest dose example, 50 milligram or 100 milligram, and gradually increase? Or is there a rough equivalent starting dose? Are there any rules for dosing while switching anti-seizure medications? It's kind of long, but I can answer it.
Dr. Beyene, do you wanna take this one?
I could barely hear. My volume is not.
Oh, okay.
Didn't hear her very well.
You can read it in the chat box, doctor.
Yeah, so I'll try to answer this question and then you can add if you have anything to add. But unfortunately the answer is no. There is no equivalent. There's if you have a patient like you said who is seizure free or was on Depakote 2,000 milligrams, there's really no way of knowing what dose of carbamazepine or any of the other medications is going to work for them. So in those instances, I do start low at the lowest dose and increase as tolerated.
Makes sense. Makes sense.
So Dr. Bezawit, pediatrician, has a question. How aggressive should I be with mitochondrial disease workup if a child presents with valproate-associated hepatotoxicity? Is the liver injury commonly dose-related or idiosyncratic?
That's a really good question. So valproate-associated hepatotoxicity, as far as I know, and Dr. Beyene, you can chime in, is not necessarily dose related. It typically happens when you first start taking the anti-seizure, the Depakote, basically. There is a mutation called like the POLG mutation that occurs in the general population, typically in kids, that should be evaluated, that this patient should be evaluated for. But I wouldn't necessarily go looking for any mitochondrial diseases in everybody who develops hepatotoxicity because it's just a common thing that happens with Depakote.
And it's a pretty rare occurrence. So yeah, and I don't think it's dose related either. It's not. There was one question actually on levetiracetam and associated with priapism. And I quickly looked it up myself. I didn't know that, but I mean that's the thing. You know, the side effects. There's certain side effects that that have been seen in the clinical trials that have been reported. But at the same time, there's post-marketing reports that that can reveal other rare side effects. So so this has happened with priapism. Doesn't I mean with levetiracetam doesn't mean it's going to happen with everybody. But if you do see it, and if a patient is on Keppra, and it's very possible. But again, it's one of those rare adverse events that can happen, and that has been presented in the literature. And you should try and present it as well if possible, if you write it up if you can.
Thank you. That was from Dr. Bahailu, pediatric neurologist. We will go to Dr. Mhella's question. She is a neurologist too, adult neurologist. What is the dosing frequency of phenytoin? Once a day or 3 times? Pros and cons.
Yeah, I mean, I guess it depends on what kind of drug that you have. So, I mean, in this country, there's regular phenytoin, and there's also the extended release. So if you have extended release, you can, dose it, less frequently. But if you have the immediate release, as you have, I think in Ethiopia, then you have to do it, twice a day or 3 times, 3 times a day most of the time. And of course, adherence, compliance is very important. So the less number of times you give to the patient, the better. But if you don't have the extended release, you have no choice.
All right. So to the next question, Konan Hunanyao asked, most anti-seizure medications are not available in the countryside except phenytoin and phenobarbital. You said both are not safe during pregnancy. Which one do you prefer to give during pregnancy?
I'll leave that up to you. I have it's difficult.
Yeah, that's unfortunate, right? So we have to work with the medications that we have.
Yeah.
Both phenobarbital and phenytoin are in pregnancy category D, which means you should avoid. But honestly, the biggest issue is seizure control, right? So obviously, if a woman of childbearing age becomes pregnant and has increased seizure frequency, that's going to increase the risk of fetal injury and as well as injury to the patient herself, right? So you pick the medication that's going to get the seizures under control, right? That's so whether it's phenytoin or phenobarbital, in this case, they're kind of equivalent. And I wouldn't necessarily, like if a patient is completely seizure free and she's on phenobarbital, she comes in and she says, I'm pregnant, would I change the dose? No, right? You don't touch it. So I think they're pretty equivalent. Maybe this is a personal thing, and I might have some preference for phenytoin, but like we talked about, phenytoin doesn't work. It's a narrow spectrum, so it doesn't work for all seizure types. And the reason why I have somewhat of a preference for phenytoin really is because with phenytoin we worry about neural tube defects, but with the phenobarbital there is an increased incidence of like fetal cardiac abnormalities, which if it's happening in the rural regions, these patients are not getting ultrasound, they're not seeing like MFM or OBs on a regular basis. So I think I have a somewhat of a preference for phenytoin for that reason.
We have many questions as this is a very challenging concept for most professionals here. So the next question is from Dr. Beyene, neurologist. A patient on anti-seizure medication came overdosed, specifically phenobarbital. When is it appropriate to restart their previous anti-seizure medication dose? Should we wait for 5 half-lives to pass, or are there other recommendations?
I don't know if there's the opportunity of doing what do you call it, plasma monitoring of anti-seizure medication. Is that available in Ethiopia? Just some. So I mean, I would go with that, and also just the symptoms and signs and symptoms of the overdose. If you see that, then you definitely, in combination with the plasma concentration, then you can once that's low enough, then you can restart it. So, but again, you have to find out why the patient overdosed. Is it is it because of, intentional, overdosing, or is it accidental? So do you want to restart that? So you have to consider that. But I would use those two to restart, I would think.
So when should we wait for 5 half-lives to pass, or are there any other recommendations is another question.
Yeah, I mean, I think that the 5 half-lives is more like a theoretical, starting point. It's a good idea, but at the same time, I think the plasma concentration, the plasma level will give you a lot, a good idea. Plus, to look at the pharmacodynamic effect, you have to look at what the actually drug is doing to the body. So you have to see if the symptoms, the drowsiness and the dizziness, sedation, all of those things have subsided before you start. But the 5 half-lives is a good, starting point, I think. But the main things are those two, I think.
All right, thank you. So Dr. Beyene has another question. Thank you, Dr. Beyene, for making this very engaging. A patient already on anti-seizure medications experienced status epilepticus and was managed according to a status protocol. Should their pre-status anti-seizure medication regimen be continued during status management? Do medications initiated solely for status epilepticus require tapering upon discontinuation, given their short-term use?
I'll let you handle that.
Okay. So it depends on why they went into status in the first place. But just to back up, if a patient who has epilepsy on anti-seizure medications comes in with status, 1,000% you would restart the medications that they're on outpatient, right? Because that's proof, unless that they went into status because they're not taking it, that's proof that whatever dose of medication that they're taking or that current regimen isn't working. And the second part about, so we start them, say a patient comes in, they're on Keppra and lamotrigine, they went into status, and you somehow loaded them with Depakote. So if the question is, do I continue Depakote or not, when they go on the outpatient side, that's going to be determined on why they went into status in the first place. If they just, stopped their anti-seizure medication or missed a few doses, then no. As long as the seizures are controlled, you don't necessarily need to continue the medication that you restarted. If they went into status because of some sort of, essentially, if it's a provoked status epilepticus, right? If they fell and injured their head and now they have intracranial hemorrhage, then definitely not. If they have some sort of infection, right? Because we know infection can lower your seizure threshold, like a urinary tract infection. Then you treat the UTI and then send them off their way on the current regimen that they came on without necessarily weaning it off. If they are taking all of the medications and there's not any provoking factors that tells us why they went into status epilepticus, then certainly you can start it. You can discharge them or treat them on whatever agent you started for the status epilepticus. And I would probably monitor for at least 6 months or so prior to like weaning them back down to their current outpatient regimen.
Okay, so thank you. Dr. Saron, CareEpilepsy Ethiopia staff has another question. If the mentioned antibiotics need to be used, should we increase the dose of anti-seizure medication the patient is on temporarily till the course of the antibiotic is over?
That's a really good question. So this like we talked about, sort of like the infection, obviously they need to use antibiotics because they have some sort of infection. So that's going to lower the seizure threshold. And then in addition to that, some of the antibiotics that we're going to use can lower the seizure threshold too. But we don't typically recommend increasing the medication just in case a seizure might happen. Obviously, if they went into status or something like that, then we would do that. But it's typically not recommended. I think the recommendation is to look at that list and basically say like, is there an antibiotic that we can use that's not on that list, so that we're treating them for whatever infection they have without necessarily increasing the risk of having seizure recurrence.
Before going to the next question, we're going to have a session on management of status epilepticus on our next webinar series, so please stay tuned for that. So the next question is from Dr. Brooke Katama, a neurologist. In our setting, where older anti-seizure medications like phenobarbital and phenytoin are still widely used, cognitive impairment among epilepsy patients is frequently observed. Based on your experience, when should we consider transitioning patients to more cognitively friendly anti-seizure medications?
Good question.
Yeah.
Soon as possible.
Mhm.
Yeah, I mean, if there are medications that are available that are better tolerated, definitely go for that as soon as possible.
Yeah, I would definitely agree with that, and especially depending on the kind of work that the patient does, or if you have any option to switch to a much better adverse event profile medication, definitely I would do that.
Dr. Blaine asks, if seizure is uncontrolled despite a maximum phenytoin dose, is carbamazepine a next option, considering their similar mechanism of action? Wouldn't a drug with a different mechanism of action be more appropriate?
Yeah, that's a good question. I think it depends on what medication you have available, right? So, and also depends on what type of epilepsy you're treating. So if it's focal, then phenytoin and carbamazepine might be, good medication choices. Again, I think it depends on what access you have to different anti-seizure medications. So ideally, medications that have different mechanism of actions are better than putting on a patient onto sodium channel blocking medications. One is that, you might be able to get better seizure control if the mechanism action is different. And then the other is you're reducing the sodium channel side effects that we think of, right? Like the diplopia, the dizziness, the imbalance, things like that. They're going to experience that more if you have them on, a medication that has the same mechanism of action.
Yeah, and just to add to that, I mean, definitely, at least theoretically, it's better to use different mechanism of action drugs. But sometimes you see, for example, I used to work with eslicarbazepine, which is very similar to carbamazepine. And we had like 50% of the patients on eslicarbazepine was also on carbamazepine. And patients had, good, seizure control. So, it's again, there's a theory and actually practice, because we don't know exactly how these drugs work. We have a general idea, but we're not 100% sure. So if you have no choice, you can mix and match, but still you might get adequate response. But if you have a choice, definitely use different mechanism.
Thank you. The questions are many, so I require your patience. Dr. Zemart asks, when can we say the seizure is well controlled?
So we define that seizures are well controlled. Really, if they've been seizure free for at least a year, or if you have gotten approximately like 60% reduction in their seizure frequency, basically from like the previous year. That's not really like that. That's more like the definition I think that academic centers use. I don't know if that's like what people use, but that would be what I would consider if you've been seizure free for a year, or if we have reduced your seizure frequency by 60% compared to the previous year.
Yeah, and then in general, I mean, as Dr. Zaganat mentioned, I mean, in general, theoretically, at least 70% of patients are able to be controlled. 100% of their seizures are improved with with the medication. So that should be the goal. So if you try and patients are still having seizures, you should try and go to 100% as much as possible. But if not, then then we can settle for a lower goal.
In a patient who had previous history of recurrence after discontinuing the medication, when can we discontinue the medication? When the patient becomes seizure free? I think this one is covered.
No, I think she's asking if we wean the patient off the first time and they had seizure recurrence, but now they're seizure free again for 2 years, seizure free again, when can we wean it off? It's the same basically that I would wait 2 years prior to. And then this would probably be a patient that I would do an EEG prior to discontinuing again. And if they have not had any updated neuroimaging, I would probably consider that too.
So the time is running. So the next question is on lifestyle modifications that can be done. It's better to be answered. Maybe you can email your questions to me and I can forward to them, Aidan. Another question is from Dr. Said. A 30 years old female with good seizure control on sodium valproate 1000 milligram came with first trimester pregnancy, 7 weeks. What is the best treatment option for the patient? Should we switch to other anti-seizure medications or continue?
Continue. The risk of changing the medication at this point actually poses an increased risk for the patient and the fetus than continuing the medication. You know that, but the baby's organs actually form between 3 weeks to 6 weeks. So she's past that point anyway. So there really isn't any significant difference we're making. Sometimes in our practice, for instance, when this happens, we bring the patients into the epilepsy monitoring unit and try to see what the minimum dose of Depakote that we can put them on, just because it is a dose-related effect. The dose-related effect is actually the risk of intellectual disability in the fetus. So we try to reduce that, but again, it has to be in a very controlled environment, and I don't think that would be something that's feasible in Ethiopia, so I wouldn't touch it.
Oh. So a patient on phenobarbital has multiple suicidal attempts. Is this an indication to change the medication?
That's a good question. So all anti-seizure medication class basically have an increased risk of, depression. And then just besides that, approximately 30% or so of people who have epilepsy also have comorbid psychiatric illness. So I wouldn't necessarily assume that the suicidal attempt is from the phenobarbital. It could certainly be because of epilepsy or some sort of underlying psychiatric illness. I would get more information before I do that. The other thing to take into consideration is it sounds like the patient is seizure free, but maybe they think they're seizure free and they're actually seizing, because you can have what we call like interictal psychosis that can happen in between seizures. So I would just kind of need more information to determine next steps. But if you felt strongly that it was the phenobarbital, then I would consider medications that have better mood effects, right? So like the lamotrigines, the Depakotes, and even carbamazepine is also like a mood stabilizer in some cases. So you could certainly do that.
So we have 2 more minutes. Can we answer Aidan's question on lifestyle modifications shortly?
So in terms of lifestyle modifications, the biggest things that I typically talk to my patients about, because that's the one that we have data on, is sleep deprivation. So certainly make sure you have a good sleep regimen. You go to bed at the same time, wake up at the same time. How sensitive people are to sleep deprivation depends on the type of epilepsy and the patient themselves. So I recommend that. The other thing is alcohol is obviously it lowers the seizure threshold. So I always tell my patients to either abstain from drinking alcohol or at least reduced alcohol. So in the US, we say for like a woman, you can have like 1 drink, which is either a glass of wine or 1 can of beer. And then for a man, it's 2. So I wouldn't recommend more than that. But even in patients who just drink one drink or 2 drinks, they can still have seizures. So that's something that I talk to them about and kind of just leave it up to them. The other stuff is essentially making sure you take your medication. So use reminders, use other people or some pill organizers to take your anti-seizure medications. And then if you have uncontrolled seizures, specifically with impaired awareness, then don't drive, don't climb heights, don't go swimming alone, things like that.
All right. Before I close our webinar, can you all please turn on your camera, and we have a group picture because I love this team. It was very interactive. Can you all please turn on your cameras if you're willing?
I think people are shy, huh?
I just had to ask. All right. So, Dr. Saron, please take the pic and let's close our webinar.
I'm
Okay.
done. Thank you, everyone.
Thank you all for joining us today for this important and engaging webinar on epilepsy and anti-seizure medications. This is critically important and often challenging, so we are so grateful for our speakers for breaking it down for us each by each. So a heartfelt thank you for our distinguished speakers, Dr. Etsegenet Tizazu, Epileptologist and Neurologist, Dr. Yeshewaneh Beyene, Doctor of Pharmacy and Senior Medical Science Liaison, for their insightful presentations. I'm sure this is the voice of all participants. We are so glad that you gave this lecture today because almost all of our questions are answered. So thank you. As a reminder, participants who attended the full session and who were present at the start will be certified. We encourage you to be present on our next presentation too. On behalf of CareEpilepsy Ethiopia, thank you once again, everyone, for being part of this webinar, and our speakers, Dr. Etsegenet and Dr. Beyene. Yeshewaneh Beyene. Thank you.
Thank you all. Have a good day.
Thank you so much, Doctor.
Thank you.
All right, good night.